All right. Thank you again, Kathryn, for joining us on this interview. Um, we're just going to ask you a few questions regarding the healthcare workforce shortage. But before we delve into that, um, we want to know more about maybe your name, your current role, and how long you have been in this role.
Yeah, so I am faculty at University of Maryland. I'm an associate professor of medicine in the Division of Pulmonary and Critical Care Medicine. But I think my role here is specifically because I'm the assistant dean for admissions, and I have been in the assistant dean role since 2019 and have been involved in admissions either as an interviewer or screener for a year when I was in medical school, but then as faculty, I believe since 2013.
Wow, that's a long time ago, 2013, Thank you for sharing that with us. And then from an admission point of view, how many seats of MD/DO, and in comparison, how many residency seats do you are there within your unit or organization?
Yeah, that's a great question. So we are an allopathic school, so we're MD only. We don't have DO students. There are currently 150 seats in our School of Medicine. We do not have a set number for in-state, but we tend to run around 75%. We've been as low as 65 and as high as I think 83 in the past 5 years, but our goal is typically around 75% in-state.
Oh, thank you for sharing that. And one of the big issues that faces Maryland and indeed the entire US is healthcare workforce shortage. And what do you think is the trends among alumni to stay or move away from primary care?
So do you mean not just general physician shortage? You're talking about primary care specifically?
Yeah, primary care.
Yeah. I mean, honestly, I think the hardest thing is we pay primary care physicians poorly. Family medicine physicians, pediatrics, and primary care internal medicine are some of the most poorly reimbursed providers in medicine. And I think that that's a huge, especially when you're looking at student loans that are hundreds of thousands of dollars. Physicians are guaranteed a six-figure salary. It's good. No one, everyone is doing well in life. But when you're looking at for the same, and I would argue for harder work, because like when I see a patient in my pulmonary practice, I only need to deal with asthma and I have 20 minutes for a new visit. A lot of primary care doctors have 20 minutes for a follow-up and 40 for a new. A lot of primary providers have 15 minutes for a follow-up visit. I think that's about average in our area. And they have to deal with all of the things, including preventative care and everything else. So we're asking them to do an incredibly difficult job and reimbursing them very poorly.
Oh.
And I think our students are not dumb. Like they figured this out early on when they're doing their clerkships.
Interesting. And you see, we've talked to a couple of student and practitioners as well. And one thing that is common among this conversation is that PCP are paid poorly, right? Compared to specialists, specialists and all that. So what would you say is the percentage different in terms of percentage? If you don't have, I mean, we can understand. What are the gaps different between the PCP and the specialist?
So what you want to look at is the AAMC averages, because it varies so differently. Like as a pulmonary critical care physician, I probably make about twice as much as my primary care physician colleagues. I'm making that number up. But if you look at an orthopedic surgeon, like their bonus is my salary. So wow. There are like orders of magnitude, right? So I'm friends with an orthopedic surgeon, very good friends with an orthopedic surgeon. And it literally, his bonus in a year is what my salary is. And my salary is already probably 60 to 100% more than a primary care physician. And a little bit of that is academics. I'm in academics versus he's in private practice. But you can't say like primary care versus a specialty. It has to be primary care compared to ID. ID is also very, in my opinion, reimbursed. Procedural specialties, so within internal medicine, cardiology, GI, and pulmonary, critical care are kind of the higher reimbursed, and endocrine, infectious disease, rheumatology are less, and then primary care even less. But that's within internal medicine. Like once you get into surgery, you're making far more money than any of us do in internal medicine. Sometimes with less training, like you can become a general surgeon in 5 years, and I trained for 7 years after medical school. So this is all after medical school.
Wow.
So it's not training dependent, it's not years dependent, but you can't just say like between, it needs to be which specialty.
Wow, wow, insightful. I was going to ask I was going to ask whether it is training oriented or years of practice, but you've sort of helped me clear that. I mean, it's interesting to learn all of these details from you. What is your thought on the healthcare shortage? And what do you think we could all do to address this issue? I think statistics are on the rise that in the few years to come, there will be a number of it will be something else, that I wouldn't want to use words to sort of explain it, but it will be bad, really bad in terms of healthcare workforce. So what are your thoughts on that, and how do you think the government or stakeholder could work together to address this issue?
Yeah, and I think it's important to state that we're lucky in Maryland. We're better off than most states in the United States as far as our workforce goes. But I think that there are always two things, right? So whenever you're talking about a supply shortage, it's usually the production and the retention of providers. And I think that we can keep having more medical schools, and there's certainly international medical schools, Caribbean medical schools, DO schools. But currently, my understanding is that there's a shortage of residency positions, and these are typically Medicare or government funded, federal government funded, and we can keep expanding. We're talking about expanding the number of our medical school seats, but the problem is residents aren't matching in because there just aren't enough residency spots to accommodate all of the students who are graduating from excellent medical schools, are very, good accredited medical schools. So we need more residency and more training spots. I think that is more important than expanding the number of medical school spots, because we've been doing that over the past decade or two with increased numbers of medical schools and medical school spots. And we could attract international talent if we had more residency spots and a clear pathway to that, which I think is great. Then there's retention. Like, it just gets harder and harder to be a doctor in some ways. I love my job and I would not do anything differently, but it is really difficult when you don't feel like you can do your job well. And a lot of this comes down to reimbursement expectations for these, especially for outpatient physicians, that their visits are 15 minutes and you're asking people to document in the EMR without help of scribes, because orthopedic surgeons often have scribes. Dermatology, we see a lot of scribes. And primary care doctors often don't have the extra money to pay someone to scribe. And there's data that we spend twice as much, we as outpatient providers spend twice as much time in documentation as seeing patients. And you're being asked to see patients every 15 minutes. And you just feel like you're failing. Like, when you're asked to do this, you're not doing a good job taking care of your patients. When you have these incredibly complex patients come in, who often their concerns don't even align with their 10-year mortality values and what you're being judged on. So you feel like you're constantly failing and cannot do a good job in the current structure. And I think that inherently causes burnout.
Wow.
I mean, so I'll give you a vignette. So I have another friend who's primary care, and she worked in a practice in a nice suburban area, high socioeconomic status on average of her patients. And she had a patient panel of 2,000 patients. She was expected to see follow-up patients in 15 minutes. And she just felt like she was doing a terrible job. She now went into concierge practice where she charges, I think, $1,800 per year to be part of her concierge practice, and then also bills their insurance. She makes just as much money, but she's taking care of I think 250 people. And she just feels like she can do a good job. She wasn't looking to make more money. She actually lives in my neighborhood through both of these. She's She works. Her husband stays at home because they have a special needs daughter. And she wasn't looking to make more money. She just wanted to feel like she was doing a solid job taking care of her patients and, checking off all the boxes, making sure they got their colonoscopies and flu shots and addressing their concerns and being able to talk to them about, healthy eating and those types of things. And you just can't do that with the volume of patients we're asking our primary care providers to see on average.
Yeah, and despite asking that volume, you still earn the same amount of money, isn't it? You know, so I mean, you mentioned one thing that struck with one conversation we'll be having on this issue, and that is increasing the number of spots, for training and for residency. Could that also mean increasing the number of medical seats? I mean, I just want you to, I know you've mentioned that, but maybe you want to reiterate it. Is that plausible? To sort of closing.
Yeah. I mean, we're starting. So I just don't think that's where the gap is created. I think that the bottleneck right now is in residency spots. We keep opening medical schools. We have DOs, like classes are expanding. I think we're graduating more and more medical students every year. But back when I graduated in 2004, if you wanted to do internal or like everyone matched. If you were last in the class, like our dean said to us, and I was at University of Maryland. It's a really good medical school, top 25 or whatever, top 50, I guess. If you finish last in medical school, you're still a doctor. Like you're going to get a residency spot. And that's what it was in 2004. And now that's not true anymore. So even at one of the top state medical schools, a top 50 US medical school, I think we ranked like 30th now. If you finish in the bottom bit of your class, you're not matching. And that's crazy. These people will be good doctors. So there are people who are going unmatched and taking research years or going into industry with their MD and not providing patient care. And that's from Maryland, a super well-established school, not the Caribbean medical schools, not, some of the newer, smaller medicals, or not necessarily smaller, less well-established medical schools. So I really think the bottleneck at this point, not that we can't use more medical schools. Maryland, I think the state, there's one that they're talking about at Morgan and one in Western Maryland, and there's been talk about doing one on the Eastern Shore, like opening medical schools, which I think is great. But the concern when we sit around and talk about this is like, well, we can keep graduating MDs, but if they're not matching into residency, that is objectively unfair to the students we matriculate into an MD, because you are now leaving school with hundreds of thousands of dollars worth of debt and no clear job path, right? So that to me is like immoral. I cannot, in good consciousness, recruit students to medical school without knowing that I can get them a six-figure job on the end. And if they can't, just to pay off their loans, so I think that the bottleneck right now is really residency positions.
Can I ask a quick question?
Yeah.
Yeah, I'm from India, and actually, after our MBBS, we have to write an entrance exam for a PG exam for post graduation. Okay, so in between that time, we can practice like a primary care physician. So, what's your opinion about changing the curriculum like that? Just after medical schools, can they practice as primary care consultants or like that?
I don't think I have many friends who are MBBSs well, two of them specifically went to India. And I think it's a fascinating system. I think that you guys train very differently than we do. Like when you finish medical school in the US, you are not ready to provide care. Like there is not as, in part because I think of our litigious culture in the United States, like medical students do not get much autonomy. Like you are being very watched. I mean, even more so than back in my day, 20 years ago, right? Like there's a lot more oversight. Your hand is being held firmly all through medical school. And then, even for pediatrics, even during internship, I feel like, so they're really not at least in the litigious world of the United States, ready to go out and start practicing primary care medicine. The military has something similar, I think, where through some of the military academies, but I think it would need to be predicated on some real life experience, like working as an Army medic and then going to their medical school and then going out. You can't, I don't think, in my opinion, you get enough like autonomy during medical school to then competently go and practice medicine.
Okay. So if one student from medical school, if he's not getting residency, what will be his fate?
If they don't match into residency,
Yeah.
it depends. A lot of them will take off time and do research and try to buff up their application. The other thing you can do is just take that MD and get a job with the FDA, in government somewhere, in consulting.
Okay.
You know, and I mean, that's a little bit, you know, you need to hustle a little more for those jobs, but they definitely exist. So you just kind of take your doctorate degree and go work in industry.
Yeah.
Well, very insightful.
Or government.
You know, I thank you so much, Kathryn. We can't thank you enough for this insight which you have provided for us. But on a final note, you know, because we've learned a lot on this conversation, which would help us more. I know you've mentioned some thought, you've shared some thought in terms of the challenges regarding this PCP shortage and of course the entire workforce. And you've also touched on the ways you think these issues could be addressed. Are there any other ways that maybe you didn't mention it during the first intervention? Maybe the aspect of foreign medical trained physician. You know, I know you mentioned it earlier, but maybe you want to expand on that. You know, so maybe talk about the challenges again, maybe the ones you couldn't mention, and maybe, you know, expand on the on how to address it, especially as it relates to foreign medical trained physician.
Yeah, I think that there are a few things we can do. And one is just expand the number of spots and a clearer, more navigatable pathway for people who come in, like from other countries, to pass steps and perhaps give benefit to people who commit to staying in primary care. And then the other thing would be tuition remission or loan repayment. You know, they have it with the Indian Health Services, but I really feel like we need to start doing that for primary care providers, in addition to kind of making their practice more enjoyable as well by giving them more time with patients. I think that it is hard to look at, and I have fellows. I'm fortunate because I graduated a while ago and my interest loans were low, but with like $400,000 and $500,000, like that's a mortgage that you have to pay just in student loans. So I think like if you're, you know, if they're on the fence and they're like, well, I could do primary care, I could do cardiology, and they're looking at payments of $2,000 a month for the next 30 years, like that or more, like that influences your decision. And so I think that having some sort of loan repayment program, like they do for physician scientists, like if you stay in research, they'll help you pay your loans. I think the same would be good for primary care.
Awesome. Thank you so much, Kathryn.
No problem.
Navi, I'm not sure if you have any question or
no. I think the time is over and she's having some meetings. Yeah.
Yes.
Yeah, let me run. It was so nice meeting you. Best of luck with your project.
Yeah, thank you so much. Thank you again. Thank you.
Thank you so much. Yeah.
All right,
Bye. Yeah. Yeah, Simon, it was good. Yeah. Simon?